Welcome, I'm Ed Hope, a junior doctor in the UK, and these are my top 5 tips on being an on-call doctor. See, I can do those cool YouTube intros, I just choose not to. But welcome to my channel. I usually do videos aimed at explaining medical terms in simple terms for people who aren't really from a medical background, but I'd also thought I'd do some videos for medical students, and particularly making that difficult transition from being a medical student to being a doctor. I've done a couple of years doing lots of on-call work, both in medicine and in surgery, and more recently in the emergency department. I also work as a teaching fellow, which means I train third year and final year students. And with that, I run some on-call simulations. So simulations about carrying a bleep and jobs you get when you're being on call. So this video is going to give some of those tips that I give, from what I've learned and from what I give during those sessions. So I've made a list here on my laptop that I'm going to work through. I've got about 30 things, but in this video I'm just going to do the top 5, and if people like it, then I'm happy to do follow-up videos. If you yourself have any top tips, then please leave a comment below. Firstly, just to clarify what an on-call doctor is, I see them very much as the team that keeps everyone safe until the clever doctors can turn up in the morning. It's a really busy shift and you'll be working at the limit of your capabilities. The public perception of the word on-call normally thinks that we're in a room somewhere in our pajamas, picking up the phone, occasionally giving advice. In fact, my mum, after my first night on call, asked me if I had a comfy bed for the night, when in fact I ran around for 13 hours feeling completely out of my depth and not really knowing what I was doing. So here is a list of 5 things I wish I knew and that may help you on your first on-call. My first tip is just to go easy on yourself. In medicine, many of us are high achievers. I certainly wasn't, but many of you guys are high achievers, and you won't be used to this kind of having things out of your control and not being able to do the best all the time. Therefore, you need to look after yourself so you can put your best foot forward and handle the situation as best you can. The phrase "you can't pour from an empty cup" springs to mind. So when you have an on-call shift, make some nice preparations beforehand. So make sure you've got plenty of food in the house, maybe your favorite food. Make sure your house is nice and clean, all your washing is done. You've got your favorite bubble bath at home, maybe a couple of episodes of a TV show. So when you do get home for that, maybe half an hour or an hour you get before bed, you can watch something to unwind. Don't plan to do anything on those evenings. Just take things easy and reflect on things that have happened. This will help you massively be in a good frame of mind, and people will want to work with you. So much about being on call is about teamwork, and if you have a good team and people want to do things for each other, then that will be good for them and you'll enjoy working too. So my second tip is about triaging your bleep. So most on-call doctors will carry a pager, or what we call a bleep, to communicate jobs to them that need to be done. They tend to go off right when you don't want them to, and sometimes you even hear them when you get home from work and no longer have the bleep. Always write down the situation, so the main headline that's going on, the patient's details, and the patient's location. So when I get a message through on a pager and I've written down those 3 things, you can triage a bleep in one of 3 categories. So the first type of bleep is an emergency, and this is self-explanatory. You need to go and see the patient straight away. When you get one of these calls and during the handover you can tell something's up, you can give some basic management plan in the meantime. For example, put the patient on some oxygen. Always tell the nurse to be at the bedside and to have the notes ready for that patient, so it saves time and they can hand things over to you straight away. The second type of bleep is a non-urgent bleep that still requires you to go to the ward. For example, a drug chart that needs to be rewritten. Don't waste your time getting loads of information about these, because you know you need to go to the ward to do the job. So just get the basic details and just prioritize them accordingly. It's never good to stay late on your shift, but sometimes some of these non-urgent tasks can be done at the end of the shift after you've handed your bleep over. For example, there's a particularly complex drug chart to rewrite and you don't want to make any mistakes. Generally speaking, the day team should be doing that type of thing, but just keeping someone safe, for example, overnight or over the weekend, hand your bleep over, take 10-20 minutes at the end of the shift and sit down and do the drug chart properly. And the third type of bleep is a non-urgent bleep where you don't necessarily need to go and see the patient. So if the nurse or healthcare assistant gives you a really good handover and you're satisfied there's nothing untoward going on. For example, if someone's blood pressure has dropped a little bit at night when they've gone to sleep, you can make a plan with them to recheck, in 15 minutes or half an hour, and to bleep you back if there's any problems. And don't get annoyed when people send you these bleeps. Very often part of the procedure is they have to escalate patients when certain parameters change. So on to the third tip, and this is be comfortable prescribing fluids. I wasn't particularly good at this when I first started. I remember all the theory, but didn't actually know how to put it into practice. But just to remind you, whenever you give fluids, they're for three things. They're for maintenance fluids, if someone's nil by mouth. So the second thing is resuscitation in things like sepsis. And the third thing is replacement, so things like a high output stoma or post-obstructive diuresis or burns and things like that. Calculating replacement fluids is easy. You just need to be comfortable interpreting the input and output chart for the patient and make sure with the nurse that it is accurate. You'll need to do a quick hydration status examination of the patient, and don't forget to check their electrolytes too. For maintenance and resuscitation, the magic number is 30. That's 30 mils per kilogram. So in maintenance fluids, we need to give people 30 mils per kilogram over 24 hours. So in most people, that's 2 to 3 litres of fluid a day. You need to make sure that they're approximately getting 1 millimole per kilogram of sodium, potassium and chloride per day. And finally, about 50 to 100 grams of glucose per day. So maintenance fluids for someone my size, around about 70 kilograms, I'd need 70 times 30 amount of water, so about 2,100. So because I'm a healthy person and no chance of fluid overload, I'd say 3 litres of fluid. I'd also need 1 millimole of sodium. So in a bag of normal saline, I think there's, let me look it up, 154 millimoles. So I'm getting plenty of sodium with just one bag of normal saline. And I need 50 to 100 of dextrose. So there's 50 grams in a 5%, so I can have 2 bags of 5%. Therefore, my prescription would be 1 litre of sodium chloride, normal saline, over 8 hours, and 2 bags of 5% dextrose, each over 8 hours. So that would be my maintenance fluids for 24 hours. Don't forget you need to add the potassium in. So my weight would be 70 kilograms, therefore I need 70 millimoles. So either put 60 or 80, but divide it up throughout the day. Piece of advice, if someone's new and just comes in, for example, they're nil by mouth on a surgical take, their first bag, just give them normal saline. Don't put any potassium in or anything like that. The reason being, if that patient becomes unstable, the first thing someone might do is flush the fluid through straight away, and we don't like giving potassium too quickly. So this makes your job as an on-call very easy, because the first thing you need to put up, I'd just put up normal saline and then a bag of dextrose to follow. And the third type of fluid is the most important, resuscitation fluids, because these can save lives. We need to give them quickly and a lot in terms of sepsis and things like DKA. For example, in the severe sepsis 3-hour resuscitation bundle, it requires you to give 30 mils per kilogram as an initial fluid challenge when patients are hypovolemic or lactate is above 4. So there's the magic number again, 30 mils per kilogram. So in a patient like me, that's 2 to 3 litres. So we'd use normal saline or Hartmann's. We never use 5% dextrose because it passes out of the bloodstream very quickly and the water follows it. And we really want the fluid to stay in the blood vessels. And some places may use colloids as well, although in practice, crystalloids have been shown to be pretty much as effective. So when we're prescribing the fluid, we use the infusion section on the drug chart. We put the date, the name of the fluid, any additives, for example, potassium, the volume of that fluid, and the rate at which we want to put it over, for example, 8 hours in our maintenance example. We then sign it and put our bleep number if we need to be contacted. Okay, tip number 4, similar to the last tip, it's prescribing medications. So you need to be comfortable prescribing the main medications that you tend to do a lot of as a junior doctor on the ward. It's always a good idea to ask the nursing staff what medications they have as stock on the ward, because they're more likely to have medications that fit that set of patients that are on that specialty on the ward. And also it means there'll be no delay ordering the medication from pharmacy. So medications that spring to mind for me are analgesia. Be aware of the WHO analgesic ladder for prescribing pain relief. Antibiotics, so be comfortable prescribing these using your local hospital formulary. So on my hospital, we have it on our mobile phones. Please, 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 before prescribing antibiotics, please check there aren't any cultures on the system. So speak to the microbiology lab. If people have had recurrent chest infections, there's often a sputum sample. If they've had cellulitis from an infected ulcer, there's often a swab from the community. Or sometimes there's recurrent urine infections, we have a positive urine culture. And you just look like an idiot if you give someone some antibiotics and they've got a culture that's resistant to that antibiotic. Antiemetics, so know which antiemetic is best in the type of sickness they have. For example, in bowel obstruction, we don't give metoclopramide because that's a prokinetic. It speeds the bowel up, which can make the pain from the obstruction worse. So the last medication I recommend you be confident at prescribing is enoxaparin, or whichever heparin your hospital uses for venous thromboembolism prophylaxis. So make sure you're happy doing that VT assessment that often appears in drug charts before you're on call, so you know exactly what you're doing. Don't forget, when we treat things like pulmonary embolisms and DVTs and other things, we use treatment dose Clexane, which is a higher dose, and the dosing is based on the patient's weight. Finally, you've made it this far. This is my last tip in this set, and that is to have a framework in mind for when you see common medical complaints on the ward. For example, make sure you have a systematic approach for things like suspecting sepsis, chest pain, abdo pain, headaches, high or low blood pressure, nausea and vomiting, confused patient, and someone who's had a fall. For example, if you're called to the ward because someone has had a fall, you must think to yourself what has caused the fall. So they may have had some syncopal episode, and you also need to think about any damage from the fall. So have they broken any bones, for example, a fractured neck of femur, or have they had a head injury? So you need to have frameworks for all of those common things you see. I've just done a small list there to make sure that you have a systematic approach and make sure you're doing a good job for the patient. So those were my top 5 tips of being an on-call doctor. Hopefully it will be useful to some of you out there. They aren't necessarily the most important things. I would say the 3 most important things, just to shoehorn a bit more content in there. Escalate early. Always ask for help if you're worried. Know your A to E assessment, so you can always sit back, and if you don't know exactly what's going on, at least you'll be treating some of those symptoms as you figure things out. And the last thing, just to be nice to people. The hospital environment is a complete pressure cooker, and we often don't see the days and experiences that other people have had. Therefore, be tolerant of people around you. And if you're having stress, try not to pass that out onto other people. Thank you very much for watching. If you do have any tips yourself, please share them below. I'd love to know what they are and maybe include them in another video. And if you are about to do your first on-call shifts, then best of luck. Have faith in your training, and maybe you'll come back here and tell me all about how it went. Thanks again for watching, and goodbye.